another 15 to 20% are hemorrhagic strokes. Okay. So, just to really emphasize that idea of like it's a sudden onset of a deficit, and the deficits are really localized to a particular part of the brain. Okay, so and that's one of the really unique things about a stroke is that when you lose a particular vascular territory, you lose a particular function. Okay. So here's just the CT that just kind of gives you an idea of what a normal CT looks like, and one which there was a stroke, and one which there is a hemorrhage. This is the hemorrhage. This is the ischemic stroke. And like as most of us who aren't in the medical field look at stroke, we have like a couple of different things that people talk about. One which is looking for facial deficit, an asymmetry in his face. If there's weakness in an arm, or if there's a speech deficit, right? And that's when people call 911. The other one that's really becoming a lot more popular now, which is also taking into account like if there is posterior circulation involved, is looking at balance, whether there's an abnormality in terms of somebody's vision, okay? In addition to looking at the VAS that we just talked about. So Doris, his wife, recognized that he was having a stroke, called 911 immediately. EMS shows up. In that amount of time that Patrick presented his case, he's off to the hospital. So, why are we so aggressive with strokes? And, this 2 million neurons lost each minute with which a stroke is untreated has been talked about a lot. And it's one in which kind of forces us to be really aggressive with treatment as soon as possible. Okay? Because when we think about time in the brain, we think about like as the stroke is progressing, we start to lose more and more brain tissue, and then we kind of lose that ability to recover from the stroke. Okay? Like Dr. Muller mentioned, the best way to prevent a stroke is not to have one, but if you do have one, you want to be quick in terms of getting to the hospital. Okay? So when a stroke isn't treated, okay, people tend not to get that same level of recovery, and they tend to end up at a lower baseline than what they potentially could be. So this is time zero, normal function here, stroke here, and then treatment, you get a recovery of motor function, and without treatment, then you end up in a baseline that's really below what you potentially could be. Okay? And we all know that stroke is a leading cause of long-term disability, and just thinking about disabilities, and we all know about the weakness on one side and problems with speech, but other things to really pay attention to are like oftentimes a good portion of our patients with stroke end up having cognitive deficits that are kind of unrecognized. They can have depression as a result of the stroke or a result of having those deficits. Okay, and a good portion of our patients that do have stroke are really often dependent on other people. So in terms of costs, treating strokes costs a lot of money. We're talking billions and billions of dollars here. It really, really emphasizes the fact that we really need to be aggressive about treating stroke. Okay? Dr. Mahler mentioned this earlier in terms of thinking about reasons why we have strokes. They could be a vessel problem, it could be a heart problem, and all those things can really contribute to that blockage of a vessel that leads to a stroke. Okay? So I'm going to talk just really briefly about this really colorful slide. Just thinking about like what our brain needs in terms of like blood flow. Normal blood basically accompanies about 2% of our body weight, but uses 20% of our cardiac output. Okay, and it's about 50 cc's per 100 grams of brain tissue of blood per minute that it uses. Okay, when you have a stroke, that level starts to drop down to a critical amount. When you get down to 20 cc's per 100 grams per minute, you end up seeing electrical dysfunction in those neurons. So that person may be symptomatic. When you get down to 10 to 20, you get to the point where that patient's tissue is at risk for becoming permanently damaged. And when it becomes less than 10, that's damaged tissue. Okay? And I show you this picture because as we kind of go through this presentation, at some point we're going to talk a little bit more about like where stroke is going. And a lot of it is really recognizing like stroke early in terms of imaging and looking at blood flow. Okay? just to kind of really emphasize that, like when you see a core infarct here, which is, oops, every time I touch this mouse, that's gonna be something funny. That's the infarct. I'm gonna try using the pointer. Right there. Okay, and then this is the penumbra area that we were talking about. Okay, so this is the area that's at risk. Okay, when you've had a stroke, this is the area that's already died. And the goal of treatment is to really preserve the area around there, to limit the amount of damage that you have as a result of the stroke. So James arrived to the hospital with speech difficulty, right-sided face droop, still present. He can't move his right leg and right arm and leg and arm at this point. Okay. Doris tells the person that he was last seen normal at 7 a.m. Okay. There's a history of hypertension. He's on medications. Okay. The symptoms happened after breakfast at 9 a.m. Okay. He arrived at the hospital at 9:45. Okay. And the things to kind of really pay attention to are kind of what Patrick really alluded to, is that like in terms of us making a diagnosis, we look at the person's symptoms. And then in terms of us determining treatment, we really look at what the time of onset is. And in this particular case, the time of onset was 9 a.m. Okay, you arrived 45 minutes later. Okay? So he is evaluated by a stroke neurologist in the emergency room. The ED physician gets a chance to look at this person. It's a team effort, and they determine that this person gets TPA. Okay? He has a head CT, which looks normal, which is what we expect. Okay? So, there have been a variety of studies, and I'm not going to belabor like some of the original studies that were done in terms of looking at TPA. And I think Dr. Klingman will actually talk a little bit more about this when he does his presentation. But the one fact that I want to kind of really emphasize is that like being able to recanalize the vessel is really, really important in terms of allowing for a good functional outcome. Okay, and there have been a variety of studies that look at, if you don't do anything versus doing something. If you don't do anything, the odds of actually having a poor outcome increases significantly. The odds of you having increased mortality increases significantly. So being able to offer this person something that will hopefully break up that clot and allow revascularization or recanalization, the area right around that area of the stroke is really, really important. Okay? In thinking about stroke in general, in terms of TPA, we think about time, okay? The ability to give TPA as quickly as possible. And when we're able to do that, we see a number to treat. And what that means is, like, 1 out of every 5 people that get TPA, they're going to have a good outcome, meaning a modified Rankin scale score, which is a disability score of less than 1. Okay? If you give the medication within 90 minutes, okay, and it's the number needed to treat as you give it between 90 minutes to 3 hours, and then as you go up, it's up to 14. So it kind of really emphasizes, like when we're looking at these early studies of TPA and then more recent studies in terms of the extended time window, the importance of early time. Okay, being able to identify that patient, get them to the hospital, and then make sure that we offer them treatment in a timely fashion. So I talked a little bit about this in terms of TPA. This person actually got TPA, okay? And the blood clot starts to resolve. He gets restored blood flow. He's looking better. And he actually is able to go home with some deficits, but he's able to go home without a larger deficit, okay? Now, just kind of going back and just looking at some data that, in terms of TPA, like oftentimes we think about that first hour of symptom onset as that golden hour in terms of treatment. And typically, when patients get TPA within that first hour, their onset of actually having a really good benefit, a higher probability of having a benefit actually increases. Okay? So I'm going to talk about another case here, a second case. Okay? And as I mentioned earlier, we're going to talk about 3 cases. That was our first case. That was our TPA case. Okay? This case, second case, is a 61-year-old gentleman. Has a history of diabetes, hypertension, he has some heart disease, had 2 hours of fluctuating arm and leg weakness with occasional numbness. Had speech issues that developed 15 minutes upon arrival to the emergency room. Had like a moderately high NIH stroke score of 13. Okay? He has a CT here, which doesn't show any blood. He would qualify for TPA treatment based on it. his symptom onset, okay? And then we see here, he gets his TPA, and we look at his vessel imaging, and we see this little cutoff, okay? And that cutoff is what we consider, what Patrick mentioned earlier, which is a large vessel occlusion, or like people like to say LVO, but we don't have to say that here. But he has a large vessel occlusion here. So I think the question then becomes, like, this person got TPA. Is TPA enough to take care of this? Okay? So large vessel occlusions accompany like a large portion of strokes. 35% to 40% of all ischemic strokes. If you can imagine looking at this imaging, you can see that that occlusion here is right here. So everything beyond that is at risk for having a stroke. So the more proximal that occlusion is, the higher likelihood of you having a larger deficit. Okay? So, like, knowing that, we already know that if you have occlusion in that large vessel, your mortality kind of goes up significantly. Your likelihood of having a poor outcome actually goes up significantly. Okay? And then we know that just from data looking at large vessel occlusions, like, whereas TPA is amazing in terms of what it can do, it can't always open up these vessels in terms of looking at large vessel occlusions. Okay? So oftentimes we give TPA, and if it is an occlusion of a large vessel in the carotid artery, the percentage of like that TPA opening of the artery is 4 to 8%. And if it's in the next segment, it goes up a little bit, 24 to 32%. Okay? And then if it goes beyond that, it keeps going up. So the smaller the vessel, TPA works great. Okay? And the larger the vessel, the likelihood of it opening up drops. Okay? That's all you have to really know. And we know that, like, you know, if that clot's really long, like, TPA just has a really difficult time of really opening that vessel up. So just kind of keeping in mind here, just looking at successful opening, depending on how long that clot in terms of millimeters. And then when you get to a point somewhere around here, in that 6 to 7 millimeter length in terms of clot, TPA really has a hard time opening that clot. Okay? So I'm just going to show you a really quick video here. Oops, we'll get to it. I'm just going to skip ahead a little bit. Start right here. And you can see that person's brain, and then these are the vessels that are kind of leading up into the brain. And this is endovascular thrombectomy with a stent treatment. Okay? And 20 years ago, people thought, well, you know, we're taking out clots in the heart. Why can't we do the same thing in the brain? So it's taken a while, but they developed a significant amount of tools, and one of which is stent retriever in terms of being able to really pull these clots out of the brain. Okay? And this is just a video kind of really demonstrating that fact. Okay? And that's a catheter that they put up, and then they're going to put a stent across that clot that's in the brain. And then they're going to pull that catheter back. They're going to deploy the stent retriever, and then they're going to pull that clot. Okay? And what I will say is that this seems intuitive in terms of, like, you see a clot there, you pull it out, the person should do great. Okay? But you know, that wasn't the case with some of the early thrombectomy trials a few years ago. I think people thought you could just pull any clot out and they would do well. Well, that wasn't the case. And there it goes, and then you have restoration of blood flow. Okay? So, but because of those early trials, it really suggested that it wasn't clear whether thrombectomy was helpful, even though it seems like, you know, like from, like anybody just kind of looking at this, to be like, well, if there's a clot there, if you take it out, the person should do well. Well, that wasn't the case. You still have to pick the right patient. You have to pick the patients that will actually benefit from having that clot treated. Okay? And that occurred in terms of clinical trial design, looking at the right patient at the right time. In 2014 and 2015, there were 5 trials that were published in the New England Journal of Medicine. 5 trials on the same subject, looking at thrombectomy. Okay? And what they did was, they took patients with large vessel occlusions, okay? And they made a time parameter in which they screened these patients. They used some imaging parameter on top of that. And they took these patients who were screened properly to thrombectomy, and what they found was that in general, I'm just going to skip over to the next slide, is that when you were able to take these clots out in a timely fashion, the number needed to treat for each one of these patients with, keep in mind, a large vessel occlusion, which your mortality goes up significantly, was really, really good in the sense that, like, for the different trials, like, you had a number needed to treat from 7 to 3, okay, depending on the clinical trial, okay? And when they looked at a few of these trials together, the number needed to treat for a significant outcome of a modified ranking score of 0 to 2, or what I would consider a really good functional outcome based on this scale, was 4.2. So 1 out of every 4 patients that qualified for thrombectomy that actually had it done had a really good outcome. Okay? And in general, when you looked at these trials again, you looked at in terms of being able to move that disability scale 1 point. That number dropped to less than 3. Okay? So then, coming back to this person got TPA. Okay? And then this patient ended up getting a thrombectomy in a really timely fashion. Okay? An example is here is where this occlusion is, and you can see that this whole area, there's no blood flow in that area. Okay? This clot is taken out with this stent retriever, which I showed you, and now you have restoration of flow in that patient. This person ended up having a small burden in terms of the stroke, and then ended up leaving the hospital with minimal amount of deficits. So, like, just like I talked about in terms of TPA, in terms of time being really important. Reperfusion, the time in reperfusion is also really, really important. Okay? The time it takes from you to get that patient from the emergency room to the CT scanner to the angio suite, all those things really matter. So when we think about, like, things that happen in the hospital, which I think Dr. Klingman is going to talk a lot more about, is you need that fluid balance between, like, getting things done quickly and having all of those machines work in an efficient way to end up having patients that have good outcomes. So, and based on some of those early trials in 2015, they changed the guidelines in terms of, like you said, that this is life-saving treatment and that we should be providing thrombectomy to these patients within this time window. Okay? And they picked a time window of 6 hours. Okay? So then, comes to my third case, which is the last case that I'm going to talk about, which is case 3. And this is a case that, I think in the past, we really have a difficult time in terms of understanding what the best thing to do with this person is. So this is a 66-year-old woman found on the side of the road. Police found her with her engine stopped, right side, face, arm weakness. She can't talk. She's taken to an outside hospital. Right? She's mute. She's not moving her right side. She's sensory loss on that side, and a stroke score of 20. Okay? She has a CT, which looks really good. CT shows no hemorrhage. They have a CTA, which shows like an occlusion of that distal portion of the ICA with an M1 occlusion. So they were transferred from that outside hospital to East Davis for thrombectomy. Okay? So this person, just keep in mind, like all this time we've been talking about last known well. Like known, when was this person last known well? What was the time of onset in terms of symptoms? Okay? So in this person we don't know, except that we know that like she went to work this morning. Okay? And she was found like at the end of the day, probably driving home. Okay? So I come back to this slide again in terms of thinking about that brain perfusion that we talked about earlier in terms of what's normal, 50 to 60 cc's. What starts to be abnormal is when you get down to 20 cc's. What's penumbra tissue, that tissue at risk is 10 to 20. Okay? And then when you start to have cell death, it's below 10. Okay? So with this information, like, people have really looked at whether you can use this information in a way that's really functional. Okay? And with that said, like I'm not going to talk about all these little numbers, but what I will say is that, like with that calculation of like how long it takes for us to understand perfusion, meaning that if we bring them to a hospital, we can scan them and actually have an idea of how long it takes for blood flow to get to a particular part of the brain. So, and this type of imaging is called perfusion imaging, okay? And this is, very simply stated, is if you can imagine, like, just 5 slices of your brain, okay, kind of right here, okay? And they put you in the CT scanner, and they give you a bolus of contrast, okay? And that contrast lights up on the CT scanner, okay? And then that scanner basically scans through those 5 slices, and then, like, basically waiting for that contrast to show up in the brain, okay? And that gives us a determination of, like, how quickly that blood flow gets there, and if there are other areas in that area that don't actually fill with that contrast, or fill really, really poorly with that contrast, okay? And that gives us a good idea of where, like, using those numbers, it gives us an idea of where that core infarct is, okay? Where that tissue is probably dead already, just because that blood flow to that area is so slow to begin with, okay? It gives you an idea of where that penumbra tissue is, because it tells you, well, it's getting there, but it's getting there slower than it should be, okay? And then it tells you where the good tissue is, okay? Like, armed with that information, we're able to, at this point, make more decisions in terms of, like, how we treat these patients, okay? So just moving forward, and this is something that, I don't work for this company, Rapid, but this is an example of Rapid software, okay? In terms of thinking about, like, looking at when there's cerebral blood flow here in the magenta of less than 30%, that's core infarct. In that green slide right there, where it says green, is where there's slow flow. And if you can imagine the overlap between those two pictures, and everywhere that there isn't purple or magenta in that green, there's tissue that can be saved, okay? So just keep this picture in mind. So, with that said, there have been a lot of trials recently. I'm going to talk about these last 2 trials relatively quickly in terms of thinking about the DAWN trial and the Diffuse 3 trial, which really looked at, like, patients that fall outside of that TPA window, okay, and meet a certain criteria, whether we can treat those patients with thrombectomy alone, okay? So DAWN was published in the beginning of last year in New England Journal of Medicine, and I think you're seeing a theme here, okay? Things don't actually get published in the New England Journal of Medicine unless it's life-changing in some way, usually, okay? So the DAWN trial was kind of a multi-center trial looking at, like, last known low, 6 to 24 hours. They looked at patients at baseline that had a really good modified Rankin scale score and an NIH score of 10. Just keep that in mind, greater than 10 means probably a moderately sized stroke, okay? And I think it's just an example of what they do, okay? But I want to kind of really emphasize just a couple things here, is what they did was they took imaging, okay? And they took imaging and looked at what that patient looked like. And they divided them into groups, okay? And they used what the patient looked like to what the image looked like, and then they made the decision whether that patient would qualify for thrombectomy within this time, okay? So if they had a core infarct or a stroke less than 20 cc's, they were greater than 80 with an NIH score of 10, they would make a decision, they would get randomized, and they would take that patient to thrombectomy. Same if they were less than 80, they increased that core infarct size. And then if they were less than 80 and they had a greater than 20 NIH score with a core infarct size of 30. The 2 groups are relatively matched in terms of between the treatment arm and the control arm, okay? But probably what I want to kind of get here is, and this is just a little bit more data in terms of when their last known low was. And I think kind of really emphasize here is that, like, in general, the last known low for the 2 groups were 13 hours. But what they found was that there was significant superiority in terms of being able to, when you treated these patients with thrombectomy versus when you didn't treat these patients with thrombectomy, okay? And that they had a significant increase in terms of benefit, okay, with a modified Rankin scale score, like I mentioned earlier. If it's less than 2 or less, that's a really good outcome. 48% of these patients had a good outcome compared to 13 that didn't have the thrombectomy, okay? and they saw that thrombectomy in general led to an earlier response in terms of improvement in benefit, and then a smaller cord infarct burden, okay? Which is kind of what you would expect, okay? And that the number needed to treat, and I just want to emphasize this, one thing was around 3. So 1 out of every 3 people treated, screened properly treated, had a really good benefit. Okay? So the one really important thing about this trial, which really leads into the next trial, is that this is a study of looking at that patient and looking at the imaging. And we've been talking about all this time in terms of stroke as the big biomarker that we're looking at in terms of determining whether patients should get treatment or not. And now we have something else. We have time plus an imaging assessment. And what does that patient look like? So then that comes to Diffuse 3, which really looked at stroke between 6 and 16 hours. Okay? So again, this is a multi-center trial. It's looked at large vessel occlusions within that 6 to 16 hour range, 45 sites. They took patients with a pre-stroke modified Rankin scale of less than 2 or less. They had to have an advanced stroke score greater than 6. Okay, and they did something just a little bit different in terms of outside of that baseline characteristic. They really looked at perfusion imaging. Okay, so they really took advantage of seeing the large vessel occlusion, which you see here. You don't see any flow beyond this point. And then taking a look at that perfusion imaging that we mentioned, okay? And seeing that you have a cord infarct less than 70, and then you have this mismatch in terms of hyperperfuse or penumbra area, okay? And if you had a cord infarct less than 70, you had a mismatch greater than 1.8, and a mismatch volume greater than 15, they would take it for thrombectomy, okay? These are some baseline characteristics, which I'll kind of gloss over. But what they found was that the endovascular group did significantly better in terms of compared to medical therapy. Okay? And this is just a slide in terms of the difference between the two. Okay? But in the end, between Diffuse 3 and Dawn, that number needed to treat for Dawn was 3, and for Diffuse 3 it was 2. So just thinking about, we talked about TPA in terms of a number needed to treat somewhere. If you came in within 90 minutes between 4 and 5. So, but with Dawn and Diffuse 3, people that potentially have a significant amount of mortality and morbidity, if you look for that right patient, which Patrick is looking for with his screening outside the hospital, which we're looking for inside the hospital, if you treat that patient, they're going to have a really good outcome. Okay? So let's get this, and then, I think we talked a little bit about this. Actually, this is case 3. We're back to case 3. And this is what that woman's perfusion imaging looks like, okay? So she ended up having a relatively poor infarct of 49 cc's and 50 cc's, but that area at risk was 108, almost 180 cc's. She had a huge mismatch of about 130 cc's of brain tissue, a huge ratio mismatch. So she was taking the thrombectomy, she was revascularized, and she actually had a really good outcome, okay? She ended up, still had some deficits because her cord infarct was still relatively large, but she was able to go to rehab. So just to kind of put things in perspective in terms of number needed to treat for benefit, okay? We talked about TPA earlier. We talked about the SWIFT Prime and Extend IA, which were the initial trials in 2014, 2015. Number needed to treat was 3 to 4. For Dawn and Diffuse 3, it's 2 to 3. And then when you look at other things that we commonly do, that number to treat is pretty amazing, actually. So just thinking about how we can improve stroke care in terms of moving that care forward is going to be something that we really work actively towards. With that said, I'm going to end it with just a couple of quick slides in terms of 2018 guidelines. They really opened up the thrombectomy guidelines in terms of the 6 to 24 hours, assuming that you meet Dawn or Diffuse 3 criteria. And then Coming back to this slide in terms of thinking about what we've talked about throughout this entire